So now we'll just briefly have some questions, if any of you have any, and you can address them to Dr. Moore, Dr. Basappa, or Yannicka.
Any questions, sir?
I have a question not really related to the therapy or the treatment so much, but kidney function itself, is it related to other things such as, I know it's related to high blood pressure or low blood pressure, but can it be related to joint inflammation, other issues, arthritis, gout, and those kind of things?
I mean, there are systemic diseases that can cause an arthritis that can also affect the kidney. But by itself, there isn't necessarily a correlation. Certainly some treatments for joint pain and aches, some medicines that you take can damage the kidney or reduce kidney function. That's just a byproduct of. Yes, sir?
With respect to ATS,
Oh, I'm so sorry.
are there not times when you take that and you do not take Sutent because the whole purpose of that is to have your T cells attack them? Why would you join that with Sutent ever? Why wouldn't you just take it?
The vaccine?
Right.
Right. So that's a good question. And I didn't talk about it today, but there is a feeling, and there is some data to suggest that Sutent also modulates the immune system. So there may be a benefit to Sutent kind of upregulating your immune system as well. Now, I think for this study, I think the point was that I don't think they could have just done a head-to-head comparison. Okay, they couldn't just give you the vaccine and Sutent. I think ethically that would be a tough thing to pass by a research ethics board, because the vaccine certainly by itself hasn't shown proven efficacy. So you want to see if the standard of care, which is Sutent, plus the vaccine, is better than the standard of care alone. I think that's why the study was done, at least organized in that fashion. There may be some other preclinical data that suggests that the vaccine by itself is not effective on its own, that you do need perhaps that you do need one of these other agents with it. And even with immune therapy, there are some studies combining immune therapy like the nivolumab or ipilimumab with Sutent or pazopanib or axitinib, and even those are really experimental, because we don't necessarily know all of the effects on the immune system that some of our targeted agents have. And so combining them, I think, is a thought that makes sense, but isn't necessarily always going to pan out. So,
One more related to that. If you take Sutent and then you want to go into an immunotherapy trial, are you precluded at times from going into one of those trials because you've already taken Sutent?
the trials that I think are coming are more looking at the frontline setting. And so if you have had Sutent before, you may not be able to you would be excluded from this study based on their inclusion and exclusion criteria. Right? I think the hope, though, is that nivolumab versus everolimus study will be reported reasonably soon. And what we'll see is some benefit, so that after patients have had frontline therapy like sunitinib or pazopanib, they can go on to get nivolumab, which will maybe improve things for them compared to everolimus.
So what you're saying is if you were on Sutent and things were good, like they take you off,
Yep.
and the cancer came back,
Yes.
would you go on this therapy then, or would you go back to Sutent?
That would be an interesting question. I think if there's been a large lag time between when you were on Sutent and the time you came off it, from the time you came off Sutent to when you were going to restart it, I would certainly want to re-challenge you with that drug, because in my opinion, you never progressed on that drug. Again, that is barring any other reason not to give you that drug. I think the studies would have suggested that you had to progress on the previous treatment within 6 months of stopping it. So if you had a year of not being on treatment, you'd probably have to restart that agent and then show that you progressed. That's a good question, Mr. Chatters, but I think we'll have to sort that out with the powers that be that fund these agents and see what they say.
So I just got a little confused there for a minute. What you're saying is what you do is recycle the person back on the Sutent.
Yeah, because technically that person had not progressed on the therapy. you'd have had to demonstrate progression within 6 months of stopping that drug to go on to the next line of treatment. And I think that's reasonable. In my opinion, your best shot is usually your first shot with the treatment. And if you've got a drug that's still working, I'd use it up to its maximum, again, barring major toxicities. If you can't get that drug because you have side effects, that's a different story. But if you can get that drug, I would still use it.
Yes.
I'm wondering, with respect to Dr. Moore, if there's any call for transplants. If you lose a kidney completely, I know that wouldn't be your area, but are you inundated with requests for kidney transplants once one is taken out? And is there an availability?
So there is a request for a kidney transplant and people that have lost their kidney. And if you lose a kidney early on and you're totally asymptomatic, you can get a kidney transplant as soon as a kidney is available to you. There's no waiting for it. There's also an interest in people that have kidney cancer and don't want to keep their kidney, that somebody would take that kidney for transplantation. For early stage cancer, for the stage 1 cancers. So it is an issue that plays out every day in our renal transplant program, which I am a participant in. So people with kidney cancer can get kidneys. People with other cancers can too, provided they're cured of their kidney cancer or other cancer.
You're saying, provided you're cured,
Yes.
your body has to be clean of cancer for a year or something, then they would transplant or something?
So for stage 1 cancer, there's no waiting. So stage 2 and higher, without metastatic disease, there's a 5-year wait period before we would actually consider you for transplantation. If you still have metastatic disease or you have cancer, then you would not be a candidate for renal transplantation.
Is that due to supply and demand, or is that due to medical reasons? Because we hear of people going to other countries for transplants. So is it, if you have stage 4, is it because the new kidney will not react properly or might get infected, or is it just a matter of priorities?
No, it has nothing to do with that. It's the fact that your immune system, as Dr. Basappa talked about, could be monitoring your kidney cancer. And then we immune suppress you to allow you to accept an organ, your cancer may start growing again. And there's also the rarity of the organ, so if you die of your kidney cancer and you only had a kidney for a year, somebody else may have been able to use that kidney for a long period of time.
I had a kidney removed last year. It was totally cancer. Will be cancer-free now?
So with kidney cancer, depending on the stage of your cancer, when it's removed, there's risks for the cancer to come back, and the more extensive the cancer is, the greater the risk. So if you have early stage disease, so the T1 stage, the chance of that cancer coming back is less than 5%. So 95% of patients will survive 5 years. As you get into larger tumors and more advanced tumors, so stage 2 disease, the 5-year survival rate drops to 60 to 65%. And the more advanced disease, then it starts to fall off. I told you in my talk, people with advanced disease, even growing up to the heart, if it grows just as a big tumor thrombus, where it's shedding cells and those are spreading all over, some people still have a 5-year survival rate of 47%. Once it's spread, though, Dr. Basappa told you the information about how long people have to live. And with newer drugs, people are living up to 2 years, even having widespread disease. Whereas when we first trained, before these drugs, people would have months to a year to live, not 2 years. So we've doubled or tripled the life expectancy for metastatic disease.
Is there anything like that suitin? Like I've had kidney removal, and I was on the drug. Would that affect your functioning kidney? Is there any medical evidence that does more damage to the functioning kidney as well?
So the drugs actually do have a side effects on your heart and your kidney. They cause high blood pressure, and hypertension is a major side effect, which is the high blood pressure is the main factor that probably injures the kidney. But also the kidney is a very vascular structure. The center of the kidney is it has a high level of what's called growth factors. So the vascular endothelial growth factors itself produces a high amount of growth factors. So you can actually experimentally use the kidney to grow other tumors in animal models. So we grow experimental tumors under the kidney capsule because of its ability to generate blood vessels. So when you take drugs that stop the blood vessel growth, they somehow affect the ability of the kidney to perform.
So this new drug therapy, would they have basically the same effect as suitin on the surviving kidney? Would there be any benefit to taking them versus suitin?
So the targeted drug therapies, the tyrosine kinase inhibitors, and I can refer this back to Dr. Basappa, but sunitinib is a pan-tyrosine kinase inhibitor, so it doesn't only target the growth factor for vascular endothelial growth factor, it targets platelet-derived growth factors and other tyrosine kinase signals, but to a lesser degree. And drugs like pazopanib or axitinib are actually more focused, or they're more specific as they nail down to certain types of growth factors. So some of them are for angiogenesis in particular, some are for lymphogenesis, which is the lymphatic tracts, and they can narrow things down. But do they have any less side effects on the kidneys? I can't answer that. They all cause hypertension as a side effect. Naveen?
Yes, were you referring to the other targeted therapies or immune therapy?
Immune therapy.
So immune therapy, probably not. It doesn't act in the same way at all, right? It's using your immune system. Now, there is a possibility, however, that you may ramp up your immune system enough that it starts recognizing your own kidney as being foreign. Or it may just start attacking your kidney and cause what we call a nephritis or an autoimmune nephritis. So you could end up potentially with damage to your kidney because of an upregulated immune system. So it's not that the drug is causing it, but it's a byproduct of what the drug is doing or the immune therapy is doing. Right?
Maybe just have one more question?
Yes. Okay, we got two then. Go ahead.
It seems that, the booklet we got says at times you can freeze and at times there's heat, but I was reading you could have an ultrasound beam at times that would attack the cancer tumor. Is that only if the tumor is isolated and not near anything else? Or have you heard of that as a method of treatment?
So are you talking about high-frequency ultrasound to heat the tumor?
Well, they call it ultrasound beam in my research. That's probably what it is. Is that only if the tumor is separate all by itself?
Yeah, so I'm not aware of the data and outcomes on high-frequency ultrasound to heat and target the tumor. The common things that are being used right now is the radiofrequency ablation, which is that picture I showed you of the tines going in and heating up the tumor. And then the other is cryotherapy to freeze it. They work on the same principles. With high-frequency ultrasound or HIFU, we do use it for prostate cancer where they shine it all in and you have to heat up areas and overlap it because it isn't a big target. So there can be geographical misses with that, but I'm not aware of the data in renal cell cancer. And over here there was one other question.
Yeah, I was just going to say, I had my kidney removed for what I was here, 2.5 years now. And it was postponed cancer,
It was, pardon me?
full blown cancer.
Full blown, yes.
Now, maybe it was one kidney, but I never got on therapy. I
Yeah.
just wanted to go there. There was a possibility to have therapy.
Yeah.
So I guess the thing is, if you had kidney cancer and it was taken out, there really is, and there's no other cancer anywhere else that we can see. So if you had scans done and there's no cancer anyway, everyone has told you, I'm assuming to this point, that you were cancer-free. Is that right?
They told her it's in the walls of her stomach. That's what they're saying now, but
Oh, is that fairly recent?
yeah.
Okay.
You need to meet Dr. Basappa and Dr. North.
Well, yeah, so at some point in time, if that is truly proven, they'll probably try to take a biopsy and see, is that cancer? Is that the cancer? Is it kidney cancer in the wall of your stomach or not?
Her regular doctor told her that what he said was for her to just live her life because she has very bad COPD
Okay,
and there's nothing they can do for her.
okay.
Is there something that can be done?
Well, hard to say just off face value and just meeting you today, but I don't think it'd be unreasonable to warrant a consultation. I mean, I don't think it's unreasonable to have you come by and have one of us see you and review everything. That certainly is one of the things we're trying to do as a group. One thing we didn't talk about, but through the actions of Kidney Cancer Canada and through the help of Kidney Cancer Canada, we've also created this Kidney Cancer Research Network of Canada. Dr. Moore and I are both a part of, and we're trying to promote ways in which we can better manage kidney cancer, but learn more about it, become more of a patient resource, address a lot of different issues. One of the things is educating our physicians in general, and that's not just the medical oncologists that may see a number of different tumors that aren't as focused or specialized in kidney cancer per se, that myself, Dr. North, or Dr. Venner are here, but also just maybe family doctors as well, and say, hey, listen, what are the things that need to be done? Who's the patient that should be considered? It can vary, and I can't speak to the decision making of your doctor or what led them to decide that. I don't know if the cancer that you have in the wall of your stomach is kidney or not. That certainly is a very unusual place for kidney cancer to appear.
Well, I had a kidney full blown with cancer. We taken out.
Right, and fair enough. Again, not knowing all the details, I think it would warrant a consultation with us to see if there is something that we could do. All right,
Well, she can come here and talk to somebody because we're from Slave Lake.
Yep.
And they go through doctors like crazy, and she's just been bounced around. So
Sure.
I don't even know what she's going through.
Sure. I would suggest that you ask your family doctor or your doctor to send a referral to the Cross Cancer Institute. Absolutely. I see no issue or reason why we couldn't be able to see you. Okay? There's just one last thing. I don't know if we don't need to stop recording or not.
Did you want to say something?
Yeah, just as a thing, I know some of you have already been approached by me for this, but part of the Kidney Cancer Research Network is, we really do want to look at patients first, because you are the ones that are going through this ordeal. You are the ones that are living with and trying to manage your lives with kidney cancer and the therapy. And as scientists, Dr. Moore, myself, we ask questions that we think are appropriate. But what we haven't really done is kind of ask the patients, what do they want us to research? What are some issues, if you're on treatment, what are some questions that you would like to be answered? Not necessarily things that we're always looking at. And I think we sometimes do have blinders as scientists and researchers, just saying, we want outcomes, we want efficacy. But sometimes patients just want to say, hey, listen, I just, I wish my hands didn't hurt as much. Are we doing research into why patients get hand-foot syndrome? Or I wish I didn't have to take as many antihypertensive medications, or I wish there was an easier way to control my diarrhea. Not that these questions haven't been asked, haven't been asked. These are just some general examples I'm giving, but sometimes patients can really put forward good questions, like reasonable questions that we should be looking at. And so part of what I'm participating in is actually sending out surveys and asking patients themselves or their family members, what do you think we should be looking at? What are some questions that you would want answered as a patient going through this? Okay. Now I've brought some of these surveys today. They're completely anonymous. They can be done online, or if you want to fill them out by hand, you can. If you are a patient here at the Cross Cancer Institute, you can give them to your physician when you see them, or drop them off when you come back. Or if you'd like, I have an envelope that I can give you that you can just seal once you've completed the survey and send it back to us. So if you are interested in that, please approach me after the session is closed, and I'd be happy to give one to you. Okay, but just keep in mind, your voice needs to be heard, and certainly Kidney Cancer Canada has done a wonderful job of making that happen. Let's just keep adding to it. Thanks.
Wow, that's a lot of information and wonderful information, but I think it's an example of how when you are going through the experience that you're going through, that you have to be your own advocate. If you're not the one, then a family member has to be, to partner in your healthcare, to talk to your physician and be informed in what you are going through so that you can participate. I just wanted to also say thank you to Dr. Moore and Dr. Basappa, and I did hand out at registration, there were some evaluations of the evening. If you could kindly fill them out and just leave them at the front, it'll help us guide better as far as our talks are concerned and our future events. So I want to say thank you, safe travels home, and I hope you enjoyed your evening.